and mycobacterium.
Please, can you just take the introduction again? Thank you. Sorry.
Okay. Good morning, all. My name is Dr. Sawa Francis, and this morning I'll be talking to us about BURULI ulcer as part of the last 10 series of topics that has been outlined. Because of our time constraint, I will be giving us a super abridged summary of BURULI ulcer. I just sincerely hope that we all find this short notes useful. So BURULI ulcer is caused by Mycobacterium ulcerans. It's a chronic debilitating necrotizing disease of the skin and soft tissue, which has been termed by the WHO as an emerging infectious disease. It is the third pathognomonic mycobacterium after Mycobacterium tuberculosis and Mycobacterium leprae. The infection usually leads to large ulcers with extensive destruction of skin and soft tissue, sometimes involving the bones. And if this is not detected and treated early, it usually results in long-term functional disability, stigmatization, and social exclusion. Therefore, early diagnosis and treatment becomes very vital in preventing this disability and social consequences. It was first described by a man called Sir Robert Cook in patients from Buruli County in Uganda. And the causative organism was isolated in 1948 by McCallum in Bairnsdale region of Victoria, Australia. It's reported almost globally significantly is reported in over 33 countries around the world. And the greatest burden of the disease is in tropical region of West and Central Africa, Australia, and Japan. And it primarily affects children aged between 5 to 15 years. This is just a cartoon of the map of Africa showing the endemicity of BURULI ulcer. We have about 14 countries that have been confirmed to have endemicity of this disease, which includes Nigeria, Guinea, Togo, and Uganda, where there are 9 other countries that have suspected cases that include Burkina Faso, Chad, Equatorial Guinea, Liberia, and others. So Mycobacterium ulcerans is predominantly an extracellular acid-fast bacilli that occupies specific niche within the aquatic environment. And it is transmitted to humans through an unknown mechanism. And individuals are said to usually get inoculated with this organism through tiny breaks on the skin. It has incubation periods that last between 2 to 3 months. It proliferates at temperature ranges of the range between 29 to 33 degrees Celsius. And this explains why it affects mainly the skin. And at the point of entry, this organism secretes an exotoxin called myolactone. This myolactone is a polyketide with cytotoxic, analgesic, and immunosuppressive properties. There are about 4 variants of this myolactone that has been isolated, which includes the AB, the C, the D, and the E. And each of these have different degrees of potency. The myolactone AB is said to be the most powerful. And the African strains have been found to be the ones that produce more of the myolactone AB, while the Australian strain produce the myolactone C. And this myolactone is said to be the main exotoxin that is responsible for extensive chronic and necrotizing destruction of the skin, which can extend down to the papillary dermis and the subcutaneous fats, including the muscles. Sometimes it even involves the fascia and bones. And at very low concentrations, the myolactones have been found to be very, very active. Therefore, this destruction will now result in deformity and disability in the affected individual. So clinically, it has a long incubation period. And because of that, the incubation period usually lasts between 1 to 9 months. They averagely about 4.5 months. So because of that lengthy incubation period, patients do not usually even recall when it started, the inciting event. And it generally begins as a painless dermal papule or subcutaneous edematous nodule. And over a period of weeks to months, it begins to break down to form an extensive necrotic ulcer with undermined edges. At this point, I will want to just quickly give a short warning about viewer discretion, because some audiences might find these images I'm about to show very disturbing. So this just trying to show the different stages of the disease. Initially, it begins, like I said earlier, it begins as like a plug or papule, which progresses to a nodule, then it becomes edematous, and later subsequently becomes ulcerative in an extensive and severe form of the disease. So these are images of patients that have been shown to have Buruli ulcer. You can appreciate how extensive and destructive the disease could be. Okay, so the investigations that can be done, I try to limit this to specific investigations that will help us make diagnosis. Notwithstanding, that does not mean that there are some other specific supportive investigations that are also warranted in this patient. But specifically, we want to do a wound swab or a punch biopsy or a fine needle aspiration biopsy, sometimes even surgical biopsy, particularly when the surgical care is entailing an extensive form of the disease. So we subject these biopsy specimens to Zellnesen staining, and basically there you'll be looking for the acid-fast bacilli. You can also do PCR. In this PCR, you're going to get to see the genome of the bacterium. It can also be cultured, and we can also do histology. Now, these histologic specimens can reveal extensive coagulation, necrosis in the dermal collagen and the subcutaneous fat. And it could also show destruction of cutaneous nerve, blood vessels, and other adnexal tissues. Acid-fast bacilli could also be isolated, particularly in the early form of the disease. And at a much later stage, in older lesions, you could see granulomatous reactions with very few organisms that will eventually lead into cicatrization, formation, and extensive destruction of those tissues. So management-wise, the principles of management entail the use of specific antibiotics, wound care, very, very important and vital to the management of these patients. Then if it becomes extensive, we use the surgical method, which will entail excision or skin grafting. Then prevention of disability, nutrition, psychosocial support, and functional rehabilitation. Treatment of Buruli ulcers actually rely on timely and accurate diagnosis. When it is detected early and treatment is commenced early, antibiotics are said to be adequate alone without any other modalities of management. So, however, if the treatment is delayed, it will need to get to do surgical debridement, skin grafting, extensive wound care, and sometimes physical therapy may be needed to attenuate the debilitating sequelae. So in 2004, the WHO recommended a treatment protocol that divided lesions into 3 categories. Basically, that division is just based on the sequelae, that is early or late, depending on whether the disease is either mild, moderate, or severe. So in all these categories, actually, it's been recommended that each of them will receive an 8 course of antibiotics, which include rifampicin at dose of 10 milligram per kg once daily, and streptomycin 15 milligram per kg once daily as a standard of care. And prognosis, most patients will have complete healing, actually, with or without significant scarring or impairment, particularly when the disease is detected early and treatment is commenced. But however, even at that, some patients will require hospitalization that might be very prolonged, lasting up to about 3 months. It's said to have generally a low mortality rate, but with significant source of, as it's a significant source of morbidity and socio-economic burden. Quite a number of complications like debilitation, especially when there is extensive tissue destruction, and sometimes even the bones can be destroyed as a result of osteomyelitis. So, and they also have parasitical reactions, just like we find in the typical mycobacterium disease, especially when it is coexisting with an immunosuppressive conditions. When we begin to treat, we begin to see initially patient look as if it's beginning to improve, and there will be an exacerbation and exaggeration of the symptoms in these patients. So the management of those paradoxical reactions are basically also the same like we do in treatment of other mycobacterium infections. So they could also have co-infection with an organism called Masonella pestans nematode. So prevention largely involves public health effort to prevent the disease, and it entails good hygiene and other necessary environmental protection. Vaccine has also been found to be some speculations about its protection from BCG vaccine has also been noted. However, it's quite limited. Some literatures will talk about that BCG vaccines can actually prevent can give protection against the Mycobacterium ulcerans for a period of about 1 year after the vaccine has been given. But specifically, the vaccine for Mycobacterium ulcerans is something that is a subject of research currently. So thank you very much.
Yeah, thank you, Dr. Sawa, for your lucid presentation, straight to the point presentation. So if we have contributions, clarifications, or additions, please, we can go ahead. Dr. Sunday, you're in class, right? Hello, Dr. Sunday, you're in class because you take the next presentation. Okay. All right. So, Dr. Tanimo, straight to the point, brief comments, straight to the point, please.
Okay, thank you very much for this presentation. It's a good one. The pronunciation for the toxin is mycolacton, not myolacton. Mycolacton, MYCO, and completed like that. And also treatment is on phases. 3 phases are employed in the treatment of Mycobacterium ulcerans. Phase 1 is specific antimicrobial treatment for killing the Mycobacterium ulcerans, general wound care and debridement, including, as you said, oral rifampicin and streptomycin, as you said, contraindicated in pregnancy also. But you have to consider if the patient is pregnant, because it can affect also pregnant woman. So in that case, you also monitor a side effect, and also you can use rifampicin and oral clarithromycin beside as an alternative. If there is contraindication to the use of streptomycin, you can use rifampicin and the clarithromycin for the same duration. And also thermotherapy is also advised. Thermotreatment also include thermotherapy, but it needs large study to come to conclusion. So it's not well approved. So there is also the second phase 2 is the definite wound healing. Phase skin grafting are also done in phase 2. And also phase 3 follows phase 2. Phase 3 is physiotherapy to limit contracture, occurrence of contracture, for skin release, and reconstructive surgery are also done. So treatment is on phases. First phase is use of oral antibiotics. First phase is use of antibiotics. Second phase is use of skin grafting, and also third phase is physiotherapy for releasing of physiotherapy, release of contracture, and also reconstructive surgery for restoration of function. Thank you very much. And also for cosmetic reasons. Thank you very much.
Thank you so much for for a wonderful contribution, Dr. Tanimo. So, Dr. Esther, you can go ahead.
Good morning, our teachers. Good morning, everyone. Thank you, Dr. Sawa, for the presentation. Dr. Tanimo has made some of my comments. Just in addition to the clarithromycin, can also use ciprofloxacin with the rifampicin. And then you can also use steroids when they have flare-up lesions in the course of the treatment. Okay, I think he has made some of the other comments. Thank you so much.
Okay. All right. Thank you, Dr. Esther. Dr. Dalhatu.
Okay. Thank you, Dr. Sawa, for the presentation. Just in case they ask of the public health component of the disease, in Nigeria, the disease is mainly in the southern part of Nigeria. They are the common places where we find the cases. and there is a control program ongoing for it. Is domiciled in the Federal Ministry of Health, and all the state Ministry of Health and local government is coordinated together with tuberculosis, leprosy, and TB and leprosy. So they actually changed the name of the program from National TB and Leprosy Control Program to National Tuberculosis, Leprosy, and BURULI Ulcer Control Programs. Thank you.
Thank you, Dr. Dahatu, for the contribution. From the chatbot, thank you. Dr. Temi is asking, thank you for your lucid presentation. Is the duration of antibiotic the same for the different level of disease severity? So she's asking a question. Dr. Momodu says, is human-to-human transmission possible? What are the clinical forms or stage? So Dr. Sawa, over to you.
Okay, human-to-human transmission is possible, yes, but I think according to what the literature says, it's actually a very rare form of transmission that has been documented. But theoretically, yes, it is possible, particularly if the organism gets to, from an infected person, gets to contaminate and maybe a surface of skin that is ulcerated in another person. So yes, it might actually be possible, but it is a very rare form of transmission. The different stages of the disease, I cannot fully recall exactly, but it progresses generally from the initial stage where it presents like a plaque or papules, then it forms nodules, and later it becomes edematous, and subsequently it becomes ulcerative. And even the ulcers, it depends on the layers of the skin that is involved in, depending on whether there's involvement of bone and how extensive the bones are involved. I really didn't go very deep into this staging, but I would appreciate other IDU colleagues and dermatologists who shed more light on that. Antibiotics treatment, the standard duration is 8 weeks, but I'm not sure again here, but I think if need be to extend it, or to even, there are other combinations also with the rifampicin, which includes I think it's moxicillin and other medications also, depending on what the context in which the medications are being used, whether there is actually even resistance or there is a contraindication to those other medications. So if there is need for extending these antibiotics beyond 8 weeks, yes, I think it can be extended. Thank
you. Thank you, Doctor. So, any other clarifications that or contributions towards this? Okay, in the absence of any other contribution, let's Dr. Sunday, can you comment your presentation?
Can my slide be seen?
Yes, go ahead.
Good morning, my teachers and colleagues. I'll be just sharing with us some key points in schistosomiasis. Minutes. So,
your line is breaking, Dr. Sunday.
Okay. How about now, sir?
Okay, it's better.
Okay. I said schistosomiasis, also known as bilharzia or bilharziosis or snail fever, parasitic disease caused by several species of flatworm beginning schistosoma. Theodore Bilharz was the first person to describe this schistosomiasis, and specifically the hematobium species. It is commonly found in Asia, Africa, especially in water that. So the various organisms, these are called the human schistosomiasis, because there are also other types, We have the Mansoni, the Intercalotum, the Hematobion, the Japonicon, and the Maconchi. Epidemiologically, this disease is second only to malaria as most devastating parasitic disease in terms of the impact. And this statement is according to the CDC. It is considered one of the neglected tropical disease. It is an important cause of disease in many parts of the world, and most commonly in places with poor sanitation. School-age children are said to be at risk because of the contact with contaminated water, where most of them usually swim in. Then looking at Schistosoma mansoni, a subset or a species of the schistosoma that usually causes the intestinal form of schistosomiasis. The morphology, the length is there, that's about 10 to 15 millimeter long, and it has the gynecophoric canal, and this usually houses the female counterpart. And this gynecophoric canal usually contains spikes or tubercles, probably for the fixing of the female counterpart. The shorter and flatter male envelope the female, as I've said earlier, and the female is usually longer in length compared to the female. The eggs are ellipsoid and with a lateral spine. So as we can see in the diagram, it's good to note the lateral spine because it differentiates it from the other species. Geographically, the Mansoni species is found in part of South Africa, America, and Caribbean, Africa, and the Middle East. So looking at the hematobion, which is sometimes called the urinary schistosomiasis, it is also about 15 millimeters in length, and it also has the same gynecophoric canal like the Mansoni I've mentioned. In this case too, the female are also usually longer than the male, and the female in their uterus contain about 20 to 30 eggs, and the eggs are colorless, fusiform in shape, and they have a terminal spine as against the lateral spine that I've alluded to by the in the Mansoni. And these species of schistosoma are mostly found in Africa and in the Middle East, as we can see from the red painted side of the African map. Then the Japonicon, which causes the intestinal schistosomiasis, just like the Mansoni, also about 20 meters in length, and they have also the gynecophoric canal, but they lack the papillae. They are without papillae or tubercle that are present in the previous two I've mentioned. And females are also same length with the male counterpart. Their eggs are spherical, unlike the ellipsoid and the fusiform I've alluded to earlier, and have small knobs at one of the pole. So, and for this, they are majorly found in the Far East for the Japonicon. Then looking at the lifestyle, how does the infection occur from their intermediate host to human? The schistosoma, broadly, they have similar life cycle irrespective of their species. And the parasitic egg are released into the environment, mostly fresh water from infected individual, maybe by excreta. So when these parasites come in contact with water, this fresh water, there is hatching to release the free-swimming meracidium. And this meracidium infects freshwater snail, which are the intermediate host. By penetrating the snail food after infection, though close to the site of the penetration, the meracidium transforms at first into a primary sporocyte, and then as the growth continues, they now become the secondary sporocyte, which migrate to the snail hepatopancreas side ready for infectivity. Once at the hepatopancreas site, the secondary sporocyte begin to divide again and producing thousands of new parasites known as the Cercaria, which are the larvae capable of infecting mammals in this case. So this schema is just to simplify what I've just said, from the parasite entering fresh water, man comes in contact with the water and gets infected, and it goes on. During 2 days after penetration, schistosomium may remain in the skin before locating a post-capillary venom that is under the skin of woman. Then it travels to the lungs, where it changes to next form and migrates to the liver sinusoid. And all of this happen within 8 to 10 days. The juvenile or the juvenile species of Mansoni japonicum worms, specifically these two, develop an oral sucker after arriving at the liver, and it begins to feed on red blood cells. Where then the worm pairs of Mansoni and japonicum will now relocate from this sinusoid to the mesenteric or rectal veins. But for the hematobion, they migrate from the liver to the perivesical venom plexus of the bladder, ureter, and kidney. And this is how they get access to the urinary system. The parasite reach maturity in 6 to 8 weeks, at which time they begin to produce eggs. Many of the eggs pass through the wall of the blood vessels and through the intestinal wall to be passed out of the body in feces. The hematobion egg pass through the urethra or bladder wall and into the urine. That's why it is called the urinary schistosomiasis. Up to half of the egg released by the worms pair become trapped in the mesenteric vein. Not all of them get into this definitive into the intestine or the urinary tract, but some still remain in the mesenteric vein or will be washed back into the liver, where they will become lodged. Worm pairs can live in the body for an average of 4.5 years, but may persist even up to 20 years. Clinical features for schistosomiasis is a chronic disease. Many infections are subclinically symptomatic, with mild anemia and malnutrition being common in this area. Schistosomiasis, known as the Katayama fever, may occur weeks after the initial infection, especially by the Mansoni and the Japonicum species. Manifestation will include, but not limited to, abdominal pain, cough, diarrhea, fever, fatigue, and even hepatosplenomegaly. Looking at the clinical features, this could be divided into 4 stages. That is, the stage of invasion, where they lodge under the skin, that's the saccharial dermatitis, and the stage of maturation of the worms, that is where you have the acute schistosomiasis, known as the Katayama fever or Katayama syndrome. Then the stage of established infection, and lastly, the stage of the late infection, and where you now have sequelae, that is the complication of this. So in the first stage, which is the saccharial dermatitis, basically most of the symptoms are limited to the skins and also constitutional symptoms. There is a transient intermittent hypersensitivity reaction that occur, that is 10 to 15 minutes after exposure, is followed by a more prolonged delayed reaction, which developed after 12 to 24 hours and may persist for up to 15 days. The lesion is characterized by a small, red, pruritic macular rash, which progresses to purple, possibly accompanied by vesicles formation and edema. You can have pustules may be formed if secondary infection occurs, and residual pigmentation may persist for months. The next symptoms develop a few days after exposure and can be associated with transient fever, cough, and pulmonary infiltrate, as I've mentioned earlier, as well as myalgia and abdominal pain. The stage of maturation, which is the second stage that usually present with features of acute schistosomiasis, will have the following symptoms as seen on the slides: fever, rigor, sweating, headache, malaise, muscular ache, and profound weakness. And there usually this unproductive, irritating cough, and abdominal pain or swelling may result from some of the pictures I've just shown on the patient will also have diarrhea and loss of weight. When this patient has, most times they have generalized soft lymphadenopathy. I think of note is that there is a tender, enlarged liver, a large but soft spleen in this stage of disease. Then the third stage, which is the established infection. So I think for hematobium and for the intestinal schistosomiasis, there might be an overlap. So for hematobium, they usually complain of hypogastric discomfort, suprapubic pain, and dysuria. Hematuria might be present, even proteinuria and pyuria. For the intestinal schistosomiasis, usually they also have hypogastric pain, diarrhea with passage of blood or mucus in the stool. The liver may be enlarged and tender. The spleen may also be enlarged, but it is usually soft. The late stage infection and sequelae, that's where you have the complication. The urinary schistosomiasis, as the hematobium, may present with bladder calcification, ulceration, papillomas, nocturia, and dribbling of urine dribbling. Then there is this severe pain. The ureteric pathology is usually asymptomatic, but may lead to ureteric colic if the infestation is limited to the ureters, and patient might come with uremic symptoms in this case. Then the intestinal schistosomiasis will have intermittent diarrhea with or without the passage of blood or mucus in the stool. Then the colon may be tender. In between the episode of diarrhea, the stools are normal. Then bleeding from esophageal varices might result. Sometimes maybe a patient might even be mistaken for having liver disease. So how do we now laboratory diagnosis or investigation? Mostly is by demonstration of this the egg of these parasites under the microscope, whether from feces or urine. So sometimes abdominal pelvic X-ray might be helpful, but basically maybe for the urinary species, that's the hematobium. Then other investigation that might be important here is to rule out or to look for the attending complications like your EUCR, food blood count, which they usually have eosinophilia, and other auxiliary investigation that might help depending on the presentation. Then sometimes the stool, the examination of the stool and the feces might not really reveal the egg. So in this case, rectal biopsy or the bladder biopsy may demonstrate egg when stool and urine examination are negative. Then serological tests too can be done where the antibody will be demonstrated. Though not in commercial circulation, again, there is also possibility of checking for the antigen of the parasite, but it is not routinely used. So how do we treat this disease? Usually, treating the disease is use of praziquantel, which is safe and highly effective in curing an infected patient. It does not prevent reinfection, but Sacchardia and is thus not an optimum treatment for people living in endemic area. I think the point is that the praziquantel usually target the adult worm, so it has no effect in the maturing worm. Hence, some patients might need more than one treatment, more especially those living in endemic area. And it has also been said that sometimes that's why treatment is more effective, maybe after 4 to 8 weeks of being exposed or being infected by this organism, because by then they must have developed the adult worm. So other things that have been and could be used, but which are not popular, are the atelimon, which has been used in the past to treat the disease. In low dose, these toxic metalloid bound to sulfur atom in enzymes used by the parasite and kill it without harming the host. So other medication, they are there on the slide, but basically it's praziquantel that is being used. And it is interesting to know that praziquantel is also seen both in pregnancy and in lactating mothers. How do we now prevent this? Individual protection against infection is achieved by avoiding contact with all potentially contaminated fresh water in endemic area. For example, by wearing boots and other waterproof clothing. Such water, if we have to do with them, should be boiled before drinking or left to stand for at least 2 days before use for other purposes, such as washing. Should contact with water occur, the skin should be immediately rubbed vigorously with a towel. The water should not be allowed to evaporate, as this aids saccharian penetration. Then the soap and alcohol have also killed the saccharian, has been found to be to kill the saccharian, and other cream that can be used as barrier can also be used as preventive measure for those in endemic area. But again, it is interesting to know, even as we speak, there is no available vaccine for this parasitic infection. Thank you very much.
Okay, thank you, Dr. Sunday, for a lucid presentation. Any contributions, any comments? We can make it brief. Okay, Dr. Tanimo, go ahead. Hello, Dr. Tanimo, go ahead. Okay, any other contributions? Okay, Dr. Esther said that thank you so much for the lucid presentation. Female genital schistosomiasis with infertility has been reported in patients infected with schistosoma hematubium. Okay, so this is for our information.
Sorry,
Then,
can I speak?
Okay, you can go ahead.
Okay, thank you very much. Also, we should remember that schistosomiasis is not synonymous with bilharziasis, because bilharziasis is urinary schistosomiasis, while there is also intestinal type. So that is the difference. And another issue is the issue of the question they may ask is, what are can you mention 5 species of schistosomiasis? Then you mention schistosoma meconium, schistosoma intercalatum, schistosoma hematobium. What is the infective stage? The infective stage is the saccharia. And what are the complications associated with schistosomiasis? The complication associated with schistosomiasis is what? Squamous cell carcinoma for urinary tract obstruction because of the formation of granuloma, also portal hypertension in gastrointestinal type, portal hypertension, also pulmonary hypertension. Portal hypertension was associated portal barachial bleeding. And another thing is what? They have also risk of colorectal carcinoma. So these are some of the complications. If they ask us what is the complications associated with, what are the complications associated with the disease, and also how do you differentiate based on based on egg examination of the egg. You see, if based on urinary or intestinal, is what you examine. This one have terminal spine, while this one has lateral spine. For the intestinal schistosomiasis, including Mokongi, all those one is lateral spine. While for the schistosoma hematobium, the egg have terminal spine. Thank you very much. It's a very good presentation.
Thank you, Dr. Tanimo, for your contribution. Okay, Dr. Bassi.
Okay, good morning. I just want to add that it's mostly found in areas where you have dams, like in Egypt. Egypt has the highest incidence because of the dam. And you find in areas in Nigeria, like Bauchi has the Gobi Dam, where you have dams. That's just what I want to add. Thank you.
Okay. Yeah, thank you very much for your contribution. Okay. Dr. Chidima says schistosomiasis can also cause glomerular disease. Okay. Any other contribution? The next presenter, are you presenting with slides or you're presenting without slides, so that we can have the next presenter to present?
I think I can go next. I have slides.
Hello.
Yes.
Hello. Who is?
I think I can go next.
The line is breaking. Can't hear you clearly. Can't hear you
Now?
clearly.
Audible? Hello.
It's still your voice is still far away. Okay.
Okay.
Okay, Dr. Momodu say because of the heart-lung cycle, it can cause chronic pulmonary disease and pulmonary complications. Yes, Dr. Tanimo mentioned that. Dr. Shamsuddin say, what are the names of the snails for each species?
So for schistosoma hematobium, it's usually Biamplaria, while schistosoma for the intestinal schistosoma is usually Bulinus. Is it Bulinus or no? It's the reverse, I think. But check. But I think I'm interchanging them, I think.
Okay,
Dr.
all right. Yes, sir.
That is Dr. Shitu, yeah. So the snail for hematobium is Bulinus. The snail for Mansoni is the other one he mentioned, Biamplaria. Yes.
Biamplaria.
Okay, yeah. And then the one for Japonicum is the Oncomalina, if I remember.
Yes, sir. Yes, sir.
Yeah, thank you very much, sir. Okay, Dr. Emmanuel, you want to say something while we wait for Dr. Rukaya?
Hello. No, I just wanted to say my slides are ready. I could take my presentation. That's what I wanted to say.
Fine. Okay, try and share. So whoever shares first can just go ahead to see how.
Okay, I want to use my laptop to share. So it comes in at HP. Maybe it should be allowed. Once you see the identity HP, I actually logged in previously, but it looks like the host removed the HP. So if they can allow the HP again, I'll be able to share.
Okay.
Okay.
Okay. Are my slides visible, please?
Okay. Yes, Dr. Rukaya, your slides are visible. So you can go ahead.
Thank you. So I'm going to, good morning, colleagues and facilitators. I'm going to run us quickly through cutaneous larva migrans. Disclaimer, I'm neither a dermatologist nor ID physician, but I'll try to do my best. So we'll go through this quick outline. Cutaneous larva migrans is a zoonotic infestation. So when zoonotic infestations of animal worms occur in humans, they can give variant diseases. There's visceral larval migrans, ocular larval migrans, but today we're going to focus on cutaneous larva migrans. It occurs when worms, usually of the hookworm family, whose natural hosts are domestic animals like cats, dogs, cows, accidentally or incidentally infect humans. And they get trapped within the skin because they're unable to penetrate the dermis of humans to get into the lymphatics and end up in the viscera, and they're unable to reproduce. So they're kind of stuck under the skin, and they can't do anything about it. So it's also called the creeping eruption, and it's usually acquired when the larvae that are present
Yeah, Dr. Okay. Seems we've lost her for a minute.
like I was saying. Okay, so like I was saying, it can affect all ages because it just depends on the exposure. But people, so it can affect all ages, all sexes, all races. But of course, it would be like, depending on the exposure. So we can think of people who come in contact with soil frequently. So farmers, gardeners, or people whose like career is a recreational sports on the beach or something. But in addition, it also affects vacationers when they travel to a tropical location and they go sunbathing on the beach or walk barefoot or even nude, anywhere that the worms are able to penetrate, it would occur that. So, so the etiology, so other factors include low socioeconomic status. There are societies where walking barefoot is common. So the etiology, they are mainly hookworms. They're mainly hookworms, but animal hookworms, not the human hookworms. So hookworms of dog, hookworms of, so can my laptop be left in, please? I have rejoined. Thank you. So animal hookworms, including those of dogs, cats, and cattle, including Ancylostoma caninum, and some other very, not very easy to pronounce names. So let me just share this. Let me share the slides again. Okay, let me know if you're able to see. Okay, thank you.
Yeah, we're seeing you.
I hope the network cooperates. So travelers to tropical regions for vacation can pick up the infection and come back with it as their tropical souvenir, especially if they go walk barefoot in the beach or go sunbathing. And we've talked about the occupational risk from farmers and gardeners. So Ancylostoma brasiliense, it's a hookworm of dogs and cats, including domestic and wild dogs. Ancylostoma caninum, Onceneria stenocephala. I think this is mainly found in Europe, and Bunostomum phleboltomum. These are the main ones, but there are hosts of many other hookworms or nematodes that are able to cause this, including the human hookworms, which, should they have some defect and they're unable to penetrate the skin and get to the intestine where they are domiciled, then they could end up just migrating through the skin until they die. Of course, hookworms are nematodes. So just a reminder of the classification. We just talked about flukes now, trematodes, which are schistosoma. So hookworms are nematodes. So how is it transmitted and the life cycle? So when a pet or an animal passes feces, the eggs are in there and they hatch in warm, moist soil into the larvae, which mature into the infective larvae and can reinfect the animal, so continuing the transmission, or infect an accidental human host wherever they might have come in contact with soil, so the arms, the lower limbs, whichever. So what they do is, upon contact with the host, they secrete hyaluronidase, which is able to penetrate the corneal layer, and they burrow through the superficial cutaneous layers, but they're unable to penetrate the basal membrane into the dermis to make it into the lymphatic. So they're usually there within the epidermis or stuck at the dermal-epidermal junction. So they cannot reproduce or complete their life cycle, and they cause a local, mainly eosinophilic inflammation. And subsequently they die, after several weeks. So how do they present? There's often the history of either traveling or being domiciled in an endemic area and history of walking barefoot. So it starts with some tingling and pricking at the site of exposure where the larva just penetrated and entered. And eventually they have highly pruritic erythematous papule that usually progresses in a serpiginous manner. So this serpiginous morphology, let me call it, of the lesions is part of what sets it apart. And the rate of progression is slow. The rate of progression is slow, so usually 1 to 2 centimeters per day. Please, am I audible?
Yes, you're audible.
Fine. So it's slow. This differentiates from some other differential diagnoses which have a fast rate of progression. We've said they're intensely pruritic. So usually they're on the extremities, but when people sit on the beach with minimal clothing, they can have them on the buttocks, thighs. We could have vesiculobulous disease or papillopustular inflammation, but they're not as common. So these are so we see the serpiginous erythematous. So the dermatologists are here. It starts as a papule, but then it becomes this serpiginous rash. In Black people, of course, it may not be as red, but we see that snake-like tracking within the skin. It can ulcerate, of course, and in some, the inflammation may be minimal. This particular image on the right where my arrow is was a case report from, I think, Chicago or somewhere. So we see the worm right there under the skin next to the vein. So it wasn't a vein. Of course, we can have the bullous lesions in the same distribution, or they could become pustular. So initially they're serous fluid, but they could become pustular and secondary infected. Of course, we can have extensive disease. So this guy probably lied down on the beach, bare-chested or something, and then we could have on the thighs, the buttocks, elsewhere. So complications include secondary infection. This is the most common complication, usually with Staph aureus or streptococcal species, and can lead to cellulitis. They can have secondary impetiginization. Of course, they could have post-inflammatory skin changes, hyperpigmentation, all of that after it has resolved. And if the secondary infection is prolonged with streptococcal species, they could have post-streptococcal glomerulonephritis, but this is really quite rare. And they could have eosinophilic Luflus syndrome, again, pretty rare. So how do we diagnose? Is usually clinical from history and examination. However, should we want to, we could do blood tests. So a full blood count would show eosinophilia and only less than 40%, some would say 30, and it's actually non-specific. It doesn't tell you, okay, yes, this is for sure cutaneous larva migrans. We could have raised immunoglobulin E. If we want, we could do a skin biopsy. Again, it's usually not necessary, but it would reveal the nematode larvae within a circular canal just above the dermo-epidermal junction or in the superficial dermis, and the surrounding epidermis would have spongiosis and intraepidermal vesiculation with mixed inflammatory infiltrates and eosinophils. So the disease is self-limiting. So sometimes it may not require treatment if perhaps the person doesn't present early, and it resolves within 4 to 6 weeks, but the pruritus is really pretty intense. So that makes them present somewhat early sometimes. So we could use antihelminthics, either topical thiabendazole, usually said to be effective after 5 to 10 days. And when there's localized disease, this may be the treatment of choice. It prevents systemic side effects and absorption. But if there's highly extensive disease, we could use oral albendazole, ivermectin as a single dose, or mebendazole as second line. Then we give them antihistamines for pruritus. Some might consider using corticosteroids. I'm not sure if this is universally recommended. And we give antibiotics only if there's secondary bacterial infection. Cryotherapy has been tried, but it's largely ineffective, so it's not recommended. So what are the differential diagnoses? Larva currents caused by Strongyloides stercoralis is the most, like the closest differential. I'll differentiate them in the next slide. Others include all of this barrage of, so anything causing a linear rash could fall here as a differential, whether infective or non-infective, and rash, skin lesions in the distribution. So of course, but it's rather the serpiginous nature, the rate of progression, all of that is rather kind of unique that helps to differentiate it. But when there is doubt, then any of these could be possible. So differentiating larva currents from cutaneous larva migrans, this has a rapid rate of migration. So we said this is 1 to 2 centimeters per day. Larva currents migrates per hour, so it's pretty fast. And it usually evolves because it's strongyloides. Perianal region is almost invariable, while this is not the most common distribution. I mean, for cutaneous larva migrans, they have a cutaneous larva migrans has the urticaria occurring is like following the worm, but that one is more widespread. And of course, the etiology is strongyloides. So prognosis is usually good. If they have secondary bacterial infection, all that might affect the prognosis, but we can prevent by encouraging people who interact with warm soil to wear shoes, or gardeners to wear gloves, and banning dogs from beaches, because it's their waste that usually deposits the eggs in the soils, and you have beach goers coming down with the infection. That's the end of my presentation. Thank you.
All right, thank you, Dr. Ruka, for a lucid presentation. Any comments, any contributions you can go ahead and make? Any comments, any contributions? Okay, Dr. Esther.
Okay, thank you, Dr. Rukaya, for a very detailed presentation. Just to add to the differentiation. Okay, before then, the lesion, like she mentioned, the serpentinous lesions, because of our color of the skin, they may appear either darkish, like she showed in the black skin, but sometimes it can appear purplish or violaceous, as it were. Addition, the differentiation between larva currents and then CLM is the larva currents is commonly seen in immunosuppressed individuals. So it's important when you see patients with that we screen them as well. Then auto-infection is seen more in people that have cutaneous larva migrans than larva currents. And then the lesions in larva currents are more articulated as compared to that of cutaneous larva migrans. Thank you. Then sorry, again, in addition, for larva currents, the topical thiabendazole is not effective, so you have to add an oral medication to it. Thank you.
Okay. If what you could clarify, you mentioned auto-infection. Could you say that again? Or explain that auto-infection with larva migrans or larva currents?
Sorry, I didn't get.
Okay, thank you for the contribution. I was saying I didn't get the point about auto-infection.
Okay, sorry, auto-infection more in larva currents than cutaneous larva migrans.
Yes, so that's why when we're going to start chemotherapy or something of the sort, it's reasonable to do, I think, stool examination to rule out strongyloides. Because it could now determine, could now determine when the immunity is impaired. Thank you. So please, dermatologists in the house, if your papule has to be less than 1 centimeter, what do we call this? Do we still say serpiginous papule? You know, we remember classification of lesions in dermatology. A papule is like, is it 1 centimeter or 2? If it's larger, it's a nodule. But this is raised and it's larger than 1 or 2 centimeters and it's serpiginous. So what's the right term? We don't want to say lesion.
So you're describing the orientation of the lesion. A lesion that is greater than 1 centimeter and it's palpable is a plaque. So, but this is not a plaque because it gives you a pattern. So if it's homogeneous, it becomes a plaque. But because it already has a pattern, so serpentinous is good enough.
Okay.
Yes.
Okay. All right. Thank you. Thank you, Dr. Esther. Thank you, Dr. Rukaya. Dr. Momodu is asking how to differentiate cutaneous from visceral larva migrans.
Okay, they are two totally different entities. Cutaneous larva migrans is what I just described. Visceral larva migrans usually occurs in children who eat dirt. So the same, you have organisms, and that is caused by Toxocara canis and Toxocara cati. So cat and dog Toxocara. And when they pass the feces, the eggs are there and they go through the same thing, they hatch. So when you have children who play with pets or who like they have a sandbox and the cat or dog comes and plays with them and leaves some of its droppings, and as part of playing they eat, dirt, or they put dirt in their mouth. So the eggs, they consume the eggs which go and hatch in their intestines and then migrate through their organs. So they could affect anything, the liver, the spleen, the intestine, the lung, So it's the etiology is different. And the epidemiology, the people affected are usually people who pick up, for whatever reason, or children that are like crawling and pick up dirt and put in their mouth, which contains the eggs of these organisms. So it's a toxocarine infection.
All right, thank you, Dr. Okay.
Okay,
any
so
other comments?
Very, very, very rarely, cutaneous larva migrans, there have been few reports of being able to penetrate and get into the viscera. But that's like that's very extremely rare. And some are even questioning if, it was probably another organism, not cutaneous larva. Thank
you. Okay, thank you. Thank you, Dr. Okay. Any other contribution before I hand over to Dr. Christopher?
Dr. Atta, let's take the scabies question. I want to take as much. If you get scabies is straightforward. ACA. You can take, I know the HP guy, what say. Let's quickly take it, please. We don't know what they will see if you can take the others tomorrow. Yeah.
Okay, Dr. Emmanuel, can you share your slides?
Okay, is my screen visible?
It's visible, it's visible.
Okay, so let me just take a quick one on scabies. So this is the outline that I'll use: introduction, epidemiology, pathogenesis, risk factors, clinical features, diagnosis, complications, management, and prognosis. So by way of introduction, scabies is an ectoparasite infestation caused by the mite Sarcoptes scabies. And this is the picture of how it looks. It's an 8-legged organism. So now, again, in the United States, scabies may account for up to 5% of visits to dermatologists, and outbreaks are known to occur in like preschool, hospitals, nursing homes, prisons, and other institutional residences. Now, by way of epidemiology, it can affect all races and people of any social class, and is most common in children and young adults that can affect any age group. Worldwide, there are like 300 million cases of scabies each year. So it's more common in poorer countries like us with overcrowding, especially the sub-Saharan Africa. And at any time, there are approximately 130 million untreated cases. So by way of pathogenesis, just a brief one, the gravid female mite, which is approximately 0.3 millimeter in length, it burrows, they burrow superficially within the stratum corneum, depositing several eggs per day. So the 6-legged larvae mature into the 8-legged nymphs and then to the adults. So the gravid adult females emerge to the surface of the skin about 8 days later and then reinvade the skin of the same or another host. So newly fertilized female mites are transferred from person to person, mainly by direct skin-to-skin contact. So generally, scabies might die within a day or so in the absence of a suitable host. Now, the risk factors, the transfer is facilitated by the following: crowding, poor hygiene, immunosuppression. This will come into play in one particular type of scabies called the prostate or Norwegian scabies, immunosuppression. Then sharing of contaminated beddings or clothing, and prolonged or close physical contact with other persons, including sexual. So by way of clinical features, a person's initial infestation typically remains asymptomatic for up to 6 weeks before the onset of intense pruritus, but a reinfestation produces a hypersensitivity reaction without delay. So there is usually a widespread, intensely itchy, excoriated eczematous rash that is triggered by a hypersensitivity, that's an allergic reaction to the mite antigens. So pruritus is usually worse at night and disturbs sleep. So aside from pruritus, there may be small red papules, vesicles, and occasionally pustules occur anywhere on the body, but rarely on the face, except in neonates. The rash may be complicated by secondary bacterial infection. Now, the sites of predilection of the lesions are as stated here: the finger webs, the palms, the soles, the wrists, the axillae, the male genitalia, so scrotum and the like, then around the umbilicus, then around the nipples too. Some books add the thighs, the buttocks, and all of that, but basically these are the prominent ones. So this is a picture of scabies showing the itchy papules and pustules centered on the web space of the hand. So you can appreciate the hand. This can come in as a picture in the OSCE station, and then we may have to speak to it. So then there's this entity, it deserves to be discussed separately. Costed scabies previously was known as Norwegian scabies. So costed scabies is a variant that affects elderly or immunocompromised people who are infested with a large number of mites. Of note is that pruritus may be mild or absent. Individuals are highly infectious and may be the source of outbreaks if the diagnosis is delayed, which it often is due to lack of symptoms. Now, typically, they have hyperkeratotic crusted lesions that characteristically affect the hands and the feet. And there may be a widespread inflammatory rash with scaly crusted plaques resembling infected eczema or psoriasis. So, and yeah, I put up a picture of crusted scabies in a patient with chronic myeloid leukemia. Of course, that's an immunosuppressive condition. So if you can see my cursor, you can see this lesion, the crust, wanting to look like psoriasis and the like. So by way of diagnosis, the diagnosis sign is a fine linear or curved borus, a few millimeters long. Some books put it maybe 3 to 15 millimeters, about that. But these are not always visible, and dermoscopy may help. Now, the borus should be sought and unroofed with a sterile needle or scalpel blade, and the scrapings should be examined microscopically for mites, the eggs, and fecal pellets. Scabies can be confirmed by demonstrating the mite and or eggs on microscopy of potassium hydroxide treated skin scrapings from the tip of a burrow. But this is time consuming, and treatment usually is based on clinical features and risk factors. So this is a diagnostic sign, the burrow that I talk about. So burrows is evident on the palm of the hand. So you can appreciate them all over as in the picture. Then, yes, this captures on light microscopy a mite that is still in its egg, seen on light microscopy of scrapings over a burrow. Of note is that the mite has only 6 legs, unlike the adult mites, which have 8 legs, which I've stated previously. So by way of complications, these are the complications that may result in little children: neonatal septicemia, then there could be impetigo, cellulitis, and then there may be invasive bacterial infection. So resulting in things like post-streptococcal glomerulonephritis and even acute rheumatic fever. Now, by way of management, in terms of the scabicides, the FDA has approved this for the permethrin, crotenitone, the spinosad, and lindane. But of course, the commonest one there is the first one there, permethrin. So now, a topical scabicide, e.g. 5% permethrin, is applied overnight. If that's not available, then melation can be used. Also, they said benzyl benzoate is employed occasionally, but the trouble with it there is irritant and should not be used in children. Now, the ivermectin as 2 doses 2 weeks apart is effective, especially for use in communal settings, e.g. residential homes, but it's unlicensed for this indication. Pruritus takes a few weeks to settle and can be managed with antihistamine and cooling creams, such as 2% menthol. Now, for the prostate scabies, the Norwegian scabies, its own treatment is slightly more rigorous. So, meticulous barrier nursing is needed to protect staff against infestation. Hyperkeratotic scales should be removed with a keratotic agent, such as 6% salicylic acid, before application of a scabicide. And then oral ivermectin, 3 to 7 doses over 8 to 30 days is often required for effective eradication of all mites. So for the treatment to be successful, the measures listed in the box below should be followed, these measures. So I have it there. Treat all skin below the neck, including the genitalia, the palms, and the sole, and under the nails. Treat the head and neck regions in infants up to 2 years of age. Next, treat all close contact at the same time, even if asymptomatic. Third, reapply scabicide to the hands if they are washed during the treatment period. Fourth, wash or clean recently worn cloth, preferably at 60 degrees centigrade to avoid reinfection. And lastly there, repeat the application after 1 week. So these are measures if you have to achieve successful treatment. So by way of prognosis, it said that within 1 day of effective treatment, scabies infestation becomes non-communicable, but the pruritic hypersensitivity dermatitis induced by dead mites and their detritus frequently persist for weeks. Thus, unnecessary retreatment with typical agents may provoke contact dermatitis, especially from repeated applications of permethrin cream. So topical emollients, menthol and methyl salicylate products, calamine lotion, and oral antihistamines relieve itching during treatment. And then for itching that persists after effective treatment, topical glucocorticoids may calm pruritus that lingers on. So that's for prognosis. And that's the end of my presentation. Thank you.
Yeah, thank you. Thank you very much. Thank you very much, Dr. Emmanuel, for a lucid presentation. Any contributions? Any comments? Any contributions, any comments? Okay, Dr. Esther.
Okay, thank you for the presentation. Scabies is actually big. There's a lot to actually say. Maybe let me start from the back. So like you mentioned, the prostate scabies, it's seen commonly in patients that have defective immunity. Like you mentioned, we also have patients with leprosy and then patients with Down syndrome, patients that have any form of peripheral neuropathy that impairs their ability to itch. So it allows this mites to proliferate. Then for the treatment, it's actually a regimen. So it depends on the state, on the grade. It's graded as either mild, moderate, or severe, and then there's a regimen. It's a bit cumbersome, but just for us to know that it's graded. Okay. Then in pregnancy, so I'm just taking a few things that you can ask around. In pregnancy, the drugs that are safe include 5 to 10% sulfur ointment or 5% penetrine, and then 25% benzoate. We've talked about the mechanism of actions before. Please, we should look at them. Most of them are neurotoxic to the mite, and then I think specifically for permethrin, it disrupt the sodium-gated channels and then eventually lead to respiratory failure in the mite itself. Then there's something I wanted to talk about again. Okay, then for the treatment in children, the 25% benzoate is usually diluted to 12.5%. And like you mentioned, for children, you can use it above the head. And then for ivermectin, it's usually given, you give a start dose, which is 200 microgram per kg, and then you repeat a week later. Sometimes you have a little variation with center peculiarities, but most times you give for a start dose and then you repeat a week later. And then remember to treat all contacts. That's the most important thing, to treat all people in the house, launder the things that have been used within that period, their bed sheets, their carpets, their curtains. If they cannot be washed, they should be tied in a nylon and then placed under the hot sun for at least 48 hours, just to limit reinfection. So my friend is an authority in scabies. I would like her to say some things. I'm trying to remember what they can likely ask. So Dr. Adson, please, can you contribute? Scabies is quite big and they can ask anything. Can you kindly contribute? Thank you. Then I don't know if you talked about the management of the post-scabitic itch, which is actually very disturbing. So you need to give them antihistamine for a long time, sometimes as long as 6 to 8 weeks, just to manage the symptom. Thank you. Dr. Adson.
Good morning, Dr. Esther. Good morning. I think you have done a very good job covering everything. Just to add for the post-scabitic itch, sometimes you might need to add steroids, but that's for the post-scabitic itch, mainly antihistamines and steroids. But I think for the exam, I think it has been covered. Thank you very much.
Yeah, thank you. Thank you, Esther. Thank you, Linda, for a wonderful contribution. So any other contributions before I hand over to Dr. Christopher? Okay, ma. Over to you, ma.
Dr. Page. Let me see what's that. Hello, can you hear me?
Yes, we can hear you.
Yes, okay. I want to appreciate all the presenters today. I think we achieved a lot. I know it's past 8. I believe it's also a little sacrifice for our friends going for this exam. We want to answer as much as is possible, because once you are reading these things on your own, you might not get some insight as some specialists are coming in, pointing some typical things that will really help. And please, for scabies, remember it's a type 4 hypersensitivity reaction, just in case you are asked. I know the dermatologists in the house, they did a wonderful work on that. So I don't know if any of them mentioned that. And please, in case you're asked why itching is worse at night, I don't know if anybody talked on that, because I'm somewhere multitasking, so I don't know if I missed that. But you should know that itching is worse at night, just in case they ask you, why is itching worse at night? There are different reasons, really. One, it's believed that at night, people are not so busy. They are calm, so they are not distracted. So at that time, a little itch, becomes more exaggerated in their mind. So that's one reason. Two, it's also been observed that there's the hormonal interplay also comes in at that stage. Some hormones are low, while some hormones are elevated. This also makes the itch more severe at night. Just in case they come from that angle, you already have what to say. So once again, I want to thank everyone for wonderful presentations. All presenters did well. You guys are speaking like consultants already. Congratulations, congratulations, congratulations. Because of the time, 8:22, we'll just go straight. We'll meet in class tomorrow. Please, those that are yet to present, please, let's see if you can present some, and we'll do our send for tomorrow. Please, everyone, have a wonderful day. Thank you for coming to class. So I appreciate you, Dr. Atta, Dr. Yaya, Dr. Tanimo, all the presenters. Please, thank you so much. I appreciate you. We'll meet in class tomorrow.
Thank you.